Hello, everyone. This is Dr. Litvin again. Um, Last time I was here, we talked about diabetes type 1 and how it evolves and what the pathophysiology is, and that we call it juvenile diabetes, and that it's a state where the patient is insulin dependent, in fact, totally insulin dependent to the extent that his or her life depends on insulin. So without insulin administration, patient becomes very, very hyperglycemic, and of course, without glucose as a source of energy to the body tissues, there's a change to ketosis by virtue of the fact that there's fat metabolism. This causes acidosis and potentially eventually a death. So patients who present with all the symptoms of severe hyperglycemia typically end up being dehydrated and quite often need to be admitted to the hospital where they're getting IV fluids and insulin, quite often intravenously. And if they're developing high acidosis, they have to get medication for that as well. Typically, this takes several days to get them back on track. With enough insulin, enough hydration, it's possible to reverse this hyperglycemic state and get the patient back on their feet, so to speak, so that they're ready to be discharged. A lot of teaching has to be done at that point to educate the patient about insulin, about glucose, about carbohydrates. And the patient needs to be discharged from the hospital with prescriptions and with some samples of insulin after they've gotten educated about administration of insulin and how to deal with dosages and how to deal with their consumption of carbohydrates, which get translated to glucose in the blood and cause hyperglycemia. This is all very initially confusing and complex, but it has to be done, and patients who are able to internalize all that, understand it, and function in a proper manner are actually able to control their sugar. And this control is vital, first of all, to prevent a recurrent hyperglycemia and recurrent ketones and admission to the hospital in a life-dangerous situation. And of course, it's also important in order to prevent the consequences of chronic hyperglycemia. Patients are introduced to the various types of insulins, of which there are several, and they're educated into how to administer it. It has to be via injection. It's done in a subcutaneous injection. Insulin is a very sensitive molecule and cannot be ingested into the gastrointestinal tract, so it has to be injected. Various trials have not reached the market of insulins introduced in different forms. Various researchers have tried to introduce insulin via suppositories and even pills. This has not been successful. The market still does not have these medications. So today we recognize several types of insulin. In general, we're talking about quick-acting insulins and long-acting insulins. These can also be described as basal and prandial. So the basal insulins are insulins which are able to function within the body for 24 hours, and they basically serve to give the patient a certain baseline level of insulin in their body so that there's always insulin available, but they don't respond to the demands that are there when the patient has a meal. When a meal is ingested, glucose levels rise, obviously, and the basal insulin doesn't help with that. For that purpose, we have the prandial insulins, or insulins that are short-acting. They last in the body for about 4 or 5 hours. They act immediately after injection, and their levels in the serum and their activity rises to a max after an hour, approximately, after they're injected, and they usually disappear within 4 to 5 hours. So patients end up needing to know that typically they would need a single injection of basal insulin, which lasts 24 hours, and several injections of prandial insulin or fast-acting insulin, one before each meal. And the idea is to maintain the sugar, the blood glucose, relatively stable within the range of, again, between 80 and 200. One has to understand that the glucose levels change after every meal, rising to a maximum in about an hour, and then falling back to baseline within 2-3 hours. Patients are instructed to repeat this kind of profile. They take the basal in a single injection so that the fasting blood glucose levels are where we'd like them to be, which is around 100. And then they take the fast-acting insulin injections before every meal so that 2 hours after the meal, their levels are below about 150. If patients check their sugar an hour after the meal, it is typically higher and can reach all the way up to 200. If these kind of levels are maintained, then one can assume that the hemoglobin A1C, which is a measurement of 3 months worth of glucose levels, will be in the normal range, and we our guidelines are such that we would like to keep the A1C below 7%. So that's very basic insulin targets, insulin usage. What I'd like to do in the next clip is maybe show you insulin, various insulins, maybe if it's possible, how it's injected, and then move on later to other modalities of administering insulin. Insulin can be administered not just in syringes, which initially were glass and currently are plastic and disposable, but also currently in pre-filled pens, which are very popular and can be dialed to the right dosage. And also we have today, we've had for quite some time, insulin pumps, which have a container that contains insulin, and rather a reservoir, and some kind of motor with a computer that can be programmed to deliver the insulin at a certain rate. These insulin pumps are expensive, are sophisticated, and in fact today are working in conjunction with something that we call a glucose sensor, which is another unit that is able to check the glucose levels every 5 minutes. And very, very recently, we've had a hybrid artificial pancreas introduced into the marketplace, which is composed of a glucose sensor and an insulin pump, which are talking to each other. Basically, the sensor is able to measure the glucose and dictate or message to the pump and control the pump's basal rate, so that the basal rate is completely controlled by the sensor, and it's where it needs to be. And when the patient eats a meal, the patient can give the pump the information about the carbohydrates and administer manually the bolus, which would be equivalent to the fast-acting insulin. So this should be enough for this time, and next clip might be with a little bit of a demonstration. Hope you have a nice day, and see you on the next clip. Dr. Litvin.